Good evening, everybody. I'm Dr. Sangshaptak Saha, and today, today and the subsequent few 2-3 classes will be dedicated to endocrinology. I shall be covering the breadth of endocrinology over the next few classes. Today's class will mostly be on the growth hormone and not a growth hormone, on the things like SIAD and the diabetes insipidus and a bit of vasopressin, and mostly it will be on thyroid hormones and its different the different topics from thyroid hormone from which the MCQs usually come in part 1 and part 2. Both the classes, today's and the next week's or the next class, all will be based upon the theoretical part, where I shall be just be discussing the parts from where the usually the questions come, and the last class will be based upon MCQs. We shall be discussing around 40-50 MCQs in the last class. So we shall not be discussing everything about endocrinology. That is not possible in a couple of classes. We shall be just be discussing about the things that usually comes up in the MCQs. So I think once a few more the candidates join, then we shall be ready to start, which I think from 7:10 we shall start the class. So in endocrinology, before we start, endocrinology, the majority of the MCQs, they usually appear from SIAD, diabetes insipidus, thyroid related. Among thyroid also, the usual topics are thyroid malignancy, Graves' disease, the different eye signs. Then then this thyroiditis. Of course, drug induced, anything drug induced is a hot topic for MRCP as always. From thyroid, amyloid-induced thyroiditis and its types and how you differentiate. One question from every candidate, at least 1 to 2 questions, and either in part 1 and part 2 will appear in the exam. I don't think anybody can pass both part 1 and part 2 without answering a question amyloid-induced thyroiditis. Anyway, apart from these two topics which we shall discuss today, the other 2-3 important topics are the calcium-related things. That is calcium phosphate metabolism and related and the hypoparathyroidism, and a few emergencies, hypercalcemia, of malignancy, those type of things, and also adrenal gland. Definitely adrenal gland, which along with thyroid and adrenal, these are the two topics from which maximum questions come in from endocrinology. In adrenal, we shall discuss a lot of things: ACTH, cortisol, right from where they're secreted, right to the receptors on which they act, and then the adrenal crisis, additions, everything will be discussed. Please switch off please mute yourself. And yeah. So apart from these, we shall be discussing a few other short topics which I found MCQs have come in the last 5-6 years. Okay. And in the last class, we shall discuss around a few MCQs from every topic so that you get an idea. So I have basically taken up screenshots, not from any books, I mean, obviously from the books, but from the topics that I marked as important for my preparations. Now, I passed my MRCP part 1 in 2019 and part 2 in part 1 in 2016 and part 2 in 2019. So I have taken the part from those, and I have also gone through the last few years MCQs before I made this PPT, and I have tried to include the topics which have come up in the recent exams, in the recent diets, which more or less were the similar topics in the, like 4 or 5 years back also. Okay, so it's 7:09. I think we shall start. I think almost everybody who wanted to join has joined the class. It will be around 1 hour class. I don't think attention span is there for more than 1 hour. So first is that we shall start with the pituitary gland. Growth hormone we shall discuss as the last topic for the second class. So today, vasopressin first. So vasopressin, the first question that they usually ask is which receptors are involved. So V1, A, B, and V2. So the question will be based on V1, V1V, and V2. So first we shall discuss V2. V2 is cyclic MP related, whereas V1s are V1s are G protein coupled phosphodiethyl inositol mediated, the secondary messengers. Both are previous year's questions. V2, it is mostly renal. However, extra renal is also there. Why do you need to know this? Because for the renal mechanism, we are using this drug desmopressin, and which is mostly for which is an analog for vasopressin, which is more potent and long acting, and it is given intranasally. It is used for treatment of hypernatremia for this nephrogenic diabetes insipidus. Whereas for V2, the desmopressin, the extrarenal part, the extrarenal part, this causes this increased release of von Willebrand factor 8. That is why it is used for the treatment of hemophilia A and von Willebrand disease. So one is the renal part, which is for this antidiuresis part. As we know, it acts as the level of aquaporin 2 channels. And you are not using vasopressin, you are using desmopressin because it is more potent, long acting, and the route is usually intranasally. However, paroral and IV routes are also there, but for examination purpose, intranasal is good enough. The dose is 10 mics intranasally. We also have got an external component, external, that is associated release of von Willebrand factor and factor 8, and it is used for treatment of hemophilia A and VWD disease. I mean VWD and hemophilia. Whenever you study, you always make note like I am making. I am making it so that you get a habit of doing this. Then it will very easy to revise in your just 10 days, 14 days before the exam. Anyway, what about V1 A and V1 B? Why are they important? V1A acts on the vascular smooth muscle level, and the drug is terlipressin. Terlipressin is used. Terlipressin is again just like desmopressin. Just like vasopressin. It is mostly used to reduce the esophageal varices bleeding, that is in upper GI bleed. Felipressin is for theoretical part. I don't think it will act in MCQ, but it will prolong the action of local anesthesia. That is similar to adrenaline action because it acts at the level of the vascular smooth muscles and causing vasoconstriction. It also causes platelet aggregation. These are the two MCQs which are important: vasoconstriction, platelet aggregation. What about V1B? V1B acts at the level of the anterior pituitary gland. It releases ACTH. It is also associated with prolactin. We shall see why this is important. There is an MCQ based upon this. So these are the vasopressin receptors. And as you see, the whole chart is an MCQ. 6-7 MCQs have already come from this chart, single chart alone. Next is, when is it released? The main stimulus is increased osmolality of plasma. Why does this happen? Because the action is it will reduce the extracellular volume. So the main stimulus is increased osmolality of plasma. And what is the action? The action is it increases the dilute urine. So the urine osmolality will obviously decrease because dilute urine, lots of urine. Urine output will increase. If the lot of dilute urine is there, the plasma osmolality will increase, and consequently the plasma sodium will rise. So this is the action. Because MCQ, especially in the part 2, MCQ will not be directly, this thing. They will give you a case scenario where this information will be given. Then you have to correlate the DST, which is diabetes insipidus, and there is lots of vasopressin being secreted. Okay. So the main stimulus is increased osmolality of plasma. Another is hypovolemia, blood loss, hypotension, hypoglycemia, and also drugs, carbamazepine and anti-neoplastic drugs. Carbamazepine has already appeared in MCQ. Antineoplastic drugs, there are lots of examples. And for all practical purpose, it is difficult to remember every drug interaction, right? So only remember the drug interactions which are coming very frequently in the exam. And for that, you have to make a note which drug interactions are coming and note it down and revise it 1 week before the exam. Because it will be very difficult to remember carbamazepine is the cause of this increased secretion of vasopressin. But yeah, it has already come, so I have included it. Factors decreasing the secretion. So far, only the Wolfram syndrome has come in the exam. That is also 2 to 3 times in the last 5-6 years. So not very frequent, but try to remember. The others have not yet appeared in the exam. This is a direct question. What is the most likely explanation for the patient's hyponatremia who has presented following a road traffic accident, rapid pulse, low BP, low sodium, physiologic ADH secretion? Okay. That is the physiologic ADH. So this is not vasopressin, remember. There is low sodium. So the physiologic ADH secretion is appearing. So it is not pathological. So just you have to wait and observe for a few days and then repeat the sodium. Maybe it has already improved. So next question is SIAD, syndrome of inappropriate diuretic hormone release. So that is increased ADH. The ones marked in red have already appeared in the exam. The most common cause is small cell lung cancer. The other common causes are other cancers. It can be following a neurologic condition, which can be a hemorrhage, it can be meningitis, it can be other CVA, that is cerebrovascular accident. Similarly, tuberculosis, HIV can also cause it. Drugs, very important. Almost all the drugs mentioned here already come. Thiazides, SSRIs, phenothiazines, tricyclic antidepressants, vincristin, vinblastine, omeprazole, and also cyclophosphamide. So 5 to 6 drugs have already appeared, drugs causing SIAD. So these you have to remember. The previous slide I told you that you may forget that carbamazepine is a cause for production of this ADH. But here you have to remember these drugs because they have already come in the exam and it will come. SIAD and drugs. And this SIAD is a cause of acute intermittent porphyria also. It can be associated. So they may give a SIAD-like condition and so they may give a SIAD-like clinical features plus seizures. Definitely in a young female. And one of the causes will be acute intermittent porphyria, one of the options. And that will be the answer. So these are, if you know, you can answer. If you don't know, you can. It's not possible to find out the cause there and then. So CR the associated with AIP, and the question that has previously come in MRCP part 2 was this. Okay. So what is the management? The basic CR management is restriction of water intake, except a few situations. Those exceptions will not come in the exam. So if there is stop the IV fluids or fluid restriction is the option, that will be the answer. Firstly. Secondly, you have to find out whether the patient is at a risk for developing seizures or coma. If so, or if the patient is already having seizures, then you have to immediately correct the sodium with 3% NaCl. This one. But only if it is severe and if it is symptomatic. So who presents with neurologic abnormalities, that is seizures or poor GCS, then the treatment is 3% saline. Otherwise, 3% saline will not be the answer. If it is a chronic case or if the patient is like GCS is full, no seizures, then you have to just go with the fluid restriction. What about other options? Other options rarely comes in the MRCP part 1. It can come in part 2. Second line is demeclocycline. Third line is ADH, that is vasopressin, like tolvaptan. But for tolvaptan, there is side effects, especially hepatotoxicity. So another MCQ, before starting tolvaptan, you have to look at the LFTs. LFT investigation, it needs to be done. or if the hepatotoxicity already there, then tolvaptan you cannot give.